Good evening and welcome back to the State of Black Health for 2024 here at blackdoctor.org. I am your host, Dr. Renee, and today has been amazing. We have talked about obesity, we've talked about chronic conditions, we've talked about caregiving, we've talked about the screenings as far as the medical screenings that are so very important for us to stay here and healthy on this earth. Now we are talking about mental health because that is absolutely just as important as everything else. So, first of all, everyone, please share the broadcast. Do not forget to share the broadcast. I forgot to tell my guests to share too, but share the broadcast, everyone. Share. Sharing is caring. And please let us know where you're watching from. And if you have questions, type them in the chat as well, and I will try to get them answered for you. So, I'm going to bring the guests on now. So, we will start with Dr. Ashley Marie Berry. Please introduce yourself.
All right. Hello, everyone. I'm Dr. Ashley Marie Berry. I'm a child and adolescent psychiatrist, and I practice out of an academic setting in Cincinnati, Ohio. I trained at Cincinnati Children's in the Triple Board program. So that is pediatrics, adult psychiatry, child and adolescent psychiatry. I currently serve as the medical director for our partial hospitalization programs, which is an outpatient program setting. And I work with kids focusing on their anxiety, depression, and other mental health disorders. In addition, I do work with a team conducting Black youth suicide research, looking at risk factors for suicide in Black youth. And I also conduct a team that focuses on quality improvement projects and processes in the hospital around how to improve access to care. So that is primarily the work that I do, and thanks for having me.
And Dr. Erica Goodwin, who's been here so many times before.
Just a few. Thanks for having me, Dr. Renee. I'm so excited to be here again with blackdoctor.org. For all of you out here that don't know me, my name is Dr. Erica. My full government name is Dr. Goodwin. Dr. Erica Goodwin, like if you're good, you win. And I'm extremely passionate about helping people be better, do better, and live better. I'm a Harvard-trained, double board certified psychiatrist, and also hosted the hit podcast Better with Dr. Erica. I'm really passionate about helping people get on a path to really be able to have better mental health, which is very important to be able to have good quality of life. I do that through my adult telepsychiatry practice, my locum tenens work, because I also function as a traveling psychiatrist. I also am an author, including Fix Your Fairy Tale, A Woman's Guide to a Great Life, Love, and Legacy, some corporate speaking, and the podcast I mentioned earlier, Better with Dr. Erica. I do all of this to help really busy people like you, that you show up for work, you show up for your friends, you show up for your family, you show up for your community, you literally show up for everybody, and you may not show up for yourself the same way. And I do all of this to help put you in your life. And I'm just really honored to be here to have this very important conversation.
And my boy Reese, Dr. Reese.
Well, Dr. Renee, I appreciate the opportunity to be with you all this evening and my esteemed colleagues. My name is Dr. Roy Reese. I am a pediatric psychologist. I am on faculty at Morehouse School of Medicine in the Department of Psychiatry and the Department of Community Health and Preventive Medicine. I have been there for a while. The thing that I do at Morehouse is I help to train and supervise child and adolescent psychiatry fellows. I also run a program, it's a parent leadership program. I'm in the Department of Pediatrics. I'm there at Morehouse School of Medicine. Outside of Morehouse, I'm Director of Behavioral Health at Acoma Counseling and Consulting, which is an outpatient behavioral health center. The work that I do clinically and in terms of my research, I focus primarily on a patient census that's African American males, primarily adolescents and young adult men. I've been doing that work for a long time, and for me, that work has been ministry. So often, young brothers and brothers who are just getting started in life don't have spaces to kind of figure out and resolve the challenges that life presents to them in this place called the United States of America. And then in addition, I spent a good bit of time training colleagues of mine that are just beginning their careers in pediatrics and psychiatry. And so I'm very happy to be with you all this evening.
Wow. So, see, I bring you the best, you guys. So I I heard an overarching theme here with most of you, but then Erica, I think you do adults as well. So I love that it's children because we need to start at the beginning and then work our way up. Because I think that what happens, especially in our community, is that everyone was like, no, 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 they're going to call you crazy. And so they don't do therapy or see anyone. And then you have all these unresolved issues at 40, 50 years old. When if we started as a child, what could we have taken care of? So, how would a parent know that, okay, something's wrong? My child, it's not just the teen years or whatever, or the tween years. How would a parent know that I need to take my child to see somebody? Reese, Dr. Bear, yep. Go ahead.
So, I tell parents the first thing to do is to trust their gut. If something's wrong and it doesn't feel right, then it probably means that something is going on, and there's something they need to pay attention to. But the other thing that parents have is the parents have multiple indicators at their disposal to let them know kind of what's going on with their kid. They have teachers at school, they have their peer groups, they have coaches who might interact with them outside of school, and they have other adults in their life who lay eyes on their kids. And so when you start hearing things about your kid, like, hey, you know what, you seem out of it, or they seemed out of it today, but these become the things where we need to begin to check out, because the thing that where we oftentimes get into problems is the issue that's ignored that might be relatively low hanging, if addressed initially. It can become a progressive problem if it doesn't get addressed until further down the road. And sometimes we have to, and this is where I think there's a really important role for the primary care doc in the lives of kids. Like, I ask parents, do your primary care physicians, do they do mental health screenings, so that not only are you paying attention to what's going on with your kid, but the person who lays regular eyes on them annually or sometimes twice a year, are they paying attention to what's going on with their kids beyond whether they're sick or have a broken bone, or they're having a respiratory issue. So I think the biggest thing is, hey, let's pay attention, because paying attention doesn't mean that you need to come see somebody like us. Paying attention means, hey, there's something that we may need to talk about that we can course correct in the short term, and then we can evaluate, hey, do we need to get somebody else involved to get our child the help that they need? The other thing that I'm going to reiterate kind of throughout our time today, given the work I do with males, is that we should be paying attention to different things in our sons and our nephews than we do in our daughters and our nieces.
Ah, okay. And Dr. Berry, did you want to add to that?
Yes, I was just going to say, I think the main thing that I recommend is looking at changes in behavior and changes in functioning. So is this kid going to school? Is this kid able to get up, take care of themselves, like brush their teeth? Although teenagers don't love doing all of those things, but is there a change in that, what that structure of their day looks like? And is that change occurring, as Dr. Reese mentioned, across multiple settings? Is that change occurring at home, and is it occurring at school? And so you're looking at things like, how is my kid sleeping? How is my kid eating? How are they interacting with other peers? Like, it's normal that kids should want to, hang out with their friends and call their friends. So are those things different than they were before? And how long have they been different? And then what are the consequences of that? Because like, I work with a lot of kids that struggle with getting to school. They have a lot of school avoidance. They may have social anxiety. They're avoiding interacting with other kids. And then the anxiety then develops into depression because it's not being treated. So absolutely agree with the importance of that screening and monitoring occurring in that primary care setting, because they're often that first line of identification, and they help monitor when symptoms are an adjustment to a stressor versus when symptoms are now a disorder.
That is very interesting. So when I was in the 9th grade, I was accused of cheating by a teacher, and I literally used to go to like 10,000 extracurricular activities, and I quickly quit everything. I would go home and go to bed. So I usually went home and watched TV and ate, and I did nothing. I went home and went to sleep. And my mother was like, something is wrong. And of course she was right. And I went to a psychiatrist, and she She was amazing, and she diagnosed me clinically depressed, and we met, I think, every week for I forgot how long, but she was amazing. So yeah, so you know, thank God my mom recognized something was going on, and we nipped it quickly in the bud. And when I recognized in med school that something else was happening again, I recognized, I was like, okay, this is not normal. Like, I have got to go see somebody because this is not working out. And but I think it was because I had had that experience before that I kind of knew something was off again. It was like, I need to do something about this. So yes, very, very important. So Dr. Goodwin, unfortunately, Dr. Erica, you get these people that didn't really get that help when they were children, right?
Yes, and 20 hours a week I see kids. So
Oh.
I still see the kids. I see all of them these days.
And like you got both ends of the spectrum.
I think the thing is Dr. Berry and Dr. Reese brought up very important points that, you know, to piggyback is kind of the benchmark for all of it is change and impairment. And just as with your children, you know how your kids usually are. And even as adults, you kind of know where you're functioning. But the other thing is there's nothing wrong with, just as, you know, if you cough a couple of times extra and you go to the doctor to see what's up when you're coughing, you can always come and see someone. And if there's nothing going on, or it's normal development, or we're like, this is somewhere within the parameters of normal dealing with stress or grief, then you get a bill of good health and you keep it moving. You know, I think the thing is all of this stuff, just like a lot of times we'll have conversations about diabetes and high blood pressure, that when your blood sugars, and I swear there are so many commercials now about your hemoglobin A1C.
Yep.
If it's only mildly elevated or your blood pressure is mildly elevated, what does your doctor tell you? Let's do diet and exercise. Diet and exercise is a lot easier than medication and insulin. So with these kinds of issues, the sooner we catch it and get checked up, the fixes are a lot easier and a lot faster to get you to where you need to be. Because yes, that's part of the reason, you know, I feel like all of us can do a good job with this work. There are some unique perspectives that sometimes people that see adults that also see children have, as far as knowing and spending more time with the developmental side, and kind of how those young years, like you were talking about, can show up in your older years. But also some of the biggest stresses for adults, you know, you look at kind of work relationships and then child rearing. So being able to kind of look at that fully around. But it is very important to, if, you know, like they say, if you see something, say something, is if you feel like anything's out of whack or things, or you're having major changes, then to have someone just check you out.
So I want to get back to Dr. Reese. You said that there are differences between our boys and our girls. So what are some of those differences?
So, you know, and some of them are stereotypic. So this is not to say that this happens this way all the time. But I think that one of the things is, you know, boys are more likely to externalize, you know, what's happening with them. And I think one of the things that's important with African American boys and young men is that thing that's often identified as anger oftentimes is a manifestation of injury, sadness, frustration, hurt. You know, it's been given a moniker that's only interpreted in one kind of way. And so sometimes we miss the opportunity to identify what's really happening in our young men, because we're not really listening. If we think they're angry, well, what are you angry about? And you start to unpack that and you start to understand, I'm not really angry. I'm disappointed. I'm frustrated. I don't know how to handle the situation. Whereas, you know, same situation or perhaps different situation, that we might find that young women are internalizing more. And so that we find evidence that they are struggling in that particular regard. And then we're really kind of digging because we don't see the external piece, but we know that something is going on because they become less communicative, that perhaps they're isolating. The isolating for girls can look different than the isolation for boys. The other thing that happens sometimes is girls are often sometimes more inclined, that's not necessarily to talk to the adults in their life, but perhaps to talk to their peers, right? And so oftentimes the peers for adolescent girls in particular can be sources of information about what's happening. Whereas, you know, one of the things, the pieces of work that we really have to do with our adolescent males is we have to normalize help-seeking behavior, because boys and adolescents will hold it, will hold it, will hold it. And then sometimes when it comes out, it comes out in a very explosive way, because they just didn't have the coping skills, the problem-solving strategies, etc., to manage. And then the question is that when we don't understand why, this is really, I think, the most important thing, is to ask the question like, hey, what's going on? To not fill in the blank for the kid, but to kind of engage the kid in a way that allows them to help us understand what's happening with them in a way that becomes instructive. I've got so many examples of kids who got sent to me because they were engaged in disruptive behavior at school or at home, etc. These kids had anxiety disorders. These kids were depressed. These kids were struggling with trauma, etc. But if we allow the common narrative, right, it's that we've got a bad kid who's acting out, instead of, you know what, the symptom presentation looks different here, and that our job as clinicians, our jobs as parents, our jobs as teachers, is to deconstruct what's going on in a way that understands where we get it right, not where it fits the narrative that we so often kind of attribute to boys. And so that becomes, it's asking the smart questions, and also being willing to say, when we don't know, hey, I'm not sure what's happening here. Let me talk to your parents some more. Let me talk to your teacher some more. I'm going to call up Dr. So-and-so, who's your pediatrician, to see if there's any evidence of this in your records. And so, sometimes we have to play detective to make sure that we understand what's happening with the young person in a way that lets us get it right, because that's the most important piece, getting it right so that we can help that family support the relief in their child, and for that young person to become an advocate for themselves in creating relief for whatever's going on in their life.
Wow. And nowadays we have all these drugs, and you can buy them on Snapchat and all this craziness now. So how do we know the difference, or are the drugs a part of the mental health issues? I don't know.
Yes, absolutely. Substance use can be a huge part of the symptoms that we see, and sometimes they can mimic multiple mental health disorders, such as bipolar disorder, disruptive dysregulation mood disorder, depression, anxiety. And so, really, the only way that we'll know for sure is to, of course, talk to the child, try to build that rapport where they feel like they can trust to share that, and then to follow up with some testing, some urine testing, which may not always detect everything, but in hopes that that can start the path of understanding, uncovering potential substances. But that plays a huge role in particularly the work I do with adolescents, where they don't feel like they can talk to their parents about their substance use. Maybe they're doing it at school, and they're hiding it, but their behaviors are very erratic, or they're very irritable. And so that's a huge part of trying to understand that history piece, and rule out that as a contributor of the symptoms that you're observing.
Got it. So I guess with Dr. Erica, there, with adults, it could be, same thing, be substance abuse as well, could be affecting them as well. But I would say if you were a child that had these types of issues, and maybe they were never addressed, and you did use drugs as a child, what does that look like for your patients as adults?
Well, I agree with everything Dr. Berry and Dr. Reese have said. And one of the big things is no one wakes up one morning and decides they want to be a crack addict. Mm-hmm. Quite frankly, because a majority of the people that all of us see across all ages with substance issues, a lot of them have untreated trauma or some other underlying mental health condition or loss or something. People don't just all of a sudden
start self-medicating.
Yes, a lot of self-medication, especially by the time they get older. There can be some experimenting a lot of us will see in young people, and all of them don't necessarily progress to having full-fledged substance use disorders. Yes, there are different patterns of substance use. A lot of times we'll see in adolescence that can be more predictive for difficulties later. because a lot of times you'll see with adults that they may do one thing, then another thing, then another thing. And previously they changed some of the nomenclature in DSM. My feelings are still hurt that they got rid of just polysubstance dependence. Was that you'll see a lot of times with adolescents, they'll just start using whatever is around. So you'll see these weird combinations of stuff or whatever they can kind of get their hands on. But, I think the huge thing is just the prevailing culture just seems to have more drug use that's just out there. I think all of us can remember life before vaping when everybody was
Right.
vaping, and then, there was always a lot of cannabis, but there continues to be even more now that you can walk into the mall and someone's like, here's a THC or CBD shop or whatever. But yes, it shows up in, people that have, they call it dual diagnosis, when people will have a traditional mental health diagnosis and then a substance abuse diagnosis. But a lot of times you'll see people will still have some underlying mental health issues outside of addiction when you start seeing addiction, or even seeing people use it as a maladaptive coping mechanism, which basically means they're using it to cope with something, but it's not a healthy way to cope.
So I have a question. I think personally, all parents should just automatic, and I think people, period, but starting with the young people, they should go to therapy. Maybe even in elementary school, just to talk to somebody and maybe just get a baseline kind of a thing. Am I crazy?
I look at it like it should be like Oprah. You get a therapist. I feel like everyone should have one. I mean, there's something magical and spiritual and also very empowering about having a dedicated safe space for you. And also the advantage of when people have exposure to this when they're younger, then potentially it can help their emotional intelligence, being able to identify and process emotions, along with normalizing being in environments where they are able to deal with things that may impact their thoughts, feelings, or behaviors.
Where I show up on this is, people, if you ask them, and I ask parents this all the time, I say, hey, does your kid have a dentist? Yes. Does your kid have an optometrist if they wear glasses? Yes. Does your kid have a physical therapist or whatever? And oftentimes they have this list of specialists that are connected to the kid. Who's the therapist? Who's the behavioral health person that you would go to? And that's often, I don't know, right? And so I think part of the place in which we normalize what behavioral health can be is to begin to talk to people before there's an issue, which is part of why we have to get into these pediatric offices and say, hey, how are we talking about these issues here? What is this first contact? And this, because this also, we have to kind of deconstruct the privilege of having access to folks like us, right? That there are people who I see PRN, they kind of, hey, I got something going on, I need to check in. There are people that I see on a regular basis, but it's been normalized that it's okay to go talk to somebody, to see somebody. And I think that when we begin to talk earlier in the mix, that this is not just when there's a problem, to your point, Dr. Renee, that this is about, hey, this is a resource that's available to us, that just when there's something going on, we're not really sure what it is or what to do about it, we check in, they help us. It's a consultation, right? So much of the work that I do with folks is not about the ongoing treatment of a patient. It's about the brief 1-2 time contact to kind of help them problem solve, because they have the resources at home, or they're committed to kind of figuring it out. You just give them some guidance about what they do, much like their primary care doc does. Hey, do this, don't do that. Come see me if this doesn't resolve itself. And so I think that we have to figure out how we normalize those pieces, much like they go see the dentist twice a year, they go see the optometrist once a year. What's the regular frequency or cadence for checking in with a behavioral health provider for a kid and for an adult?
Yeah, and I think that so I thought it was amazing that I found out this little boy, I think he's 7. I think he has a life coach or a therapist, whatever it is. It's helpful, because I think that children, even, people are like, oh, they're just kids, but It's stressful going to school these days. It's stressful playing sports. It's stressful with the academics. I mean, all of these things. And if you can learn how to manage that stuff at that age, what kind of an amazing human being are you going to be as an adult, right? So I think that it's only fair to get them a good start. And like you said, even if it's just a check-in once every 2 years or once a year. The therapist I had here in Chicago, I saw her, I think, every week for 2 years. And my insurance got wonky, and that's why I had to stop. But she was like, I think you're good. And I was like, yeah. And the reason I told her I went there because I need to know why am I fat. So she was like, what? And we worked on it, and sure enough, I was like, oh my God, you have fixed me. And so I remember when the scale the first time went less than 200 pounds, I called her. I was like, you fixed me. It's fixed. It's not broken. It's fixed. And I had a death in the family like a month before that. And for the fact that I went to the funeral and didn't gain 20 pounds in those 3 days like I would usually do, I said, she has fixed me. So that was my girl. And I would call her sporadically, like, once or twice, maybe 3 times a year, just check in with her. So I referred her to somebody November of 2022, and they sent me a text back and was like, how old is she? And I was like, I don't know. And she goes, would she be around 70 something? I was like, yeah, I think so. And she sent me the obituary. And I haven't found anyone since. I cried my eyes out. I was like, no. And I had spoke to her that year too, but she died, I guess, like a month or 2 after I talked to her. I was like devastated, but it was like, it was kind of a PRN thing. We'd talk on the phone for like an hour and that'd be my session. I was like, I'm good. But yeah, I think that people, in order for us in our community to get rid of the stigma, I think that you need to start earlier. And like Erica said, you get a doctor, everyone gets a therapist. And it's not a big deal, because it is not a big deal in the other community. We all know that. They will proudly say I go to therapy, don't they? The kids said it in middle school that I went to, in high school. They all were like, well, I go see a therapist. It was not a big deal.
Well, that was the culture when I was doing training up at Harvard. We'd all get together on a Tuesday at happy hour and discuss therapy for the week.
Yeah. And so we need to we gotta flip the script.
Yeah, I was going to mention, I think that is one of my thoughts about why specifically we're seeing an increase in suicidal rates amongst our Black youth, is because of the stigma that's been generationally passed down, and some validity to it. Like if we think about like Tuskegee experiment and all of those like kind of historical contexts, like there's valid reasons why we did not seek healthcare in general in our community. It was actually protective not to for many people. So, that is now since for the, there are still certainly disparities and health and inequities amongst the systems. But for the most part, we want to continue to encourage seeking care. And we know that is preventative for suicides and other risky types of outcomes. So there
was a time when Black people didn't kill themselves,
right?
Well,
unheard of,
or they would not know. They just weren't talking about it.
I was going to say,
Alvin Toussaint did a book that is not new. I can't remember the name of it. It's a really, really good book that he did years ago about suicide in the Black community, and that book
Carl Bell, I think, did it.
Alvin Toussaint did one too.
Okay.
Oh, okay.
Yeah, and I don't think Carl Bell was on that one because I knew Carl Bell.
Yeah. So a couple pieces to add to the conversation that we're having. One is, I also think that we have to figure out how we promote positive mental hygiene in the absence of people coming to see us, because one of the truths is there's not enough of us. And so we have to figure out how we inculcate what we know in those spaces where kids and adults, families exist, play, worship, etc., that promote, so that we're not treating, right? They say an ounce of prevention is worth, whatever.
Found a cure.
Thank you. that's one thing. I think the other thing that we have to lift up is the applicability of kind of what behavioral health treatments to the treatment of other health conditions. So like the consultations I do around kids who've had surgeries, who are experiencing diabetes, uh, uh, those types of things, so that we don't get put into a silo that says we only do this when there's some unique manifestation of some behavioral health event. But that what we have to do, what we do, and what we know has applicability to helping to advance the treatment for that cancer, for that diabetes, for in a number of other health indicators, so that we get really tied to quality of life and wellness and well-being. So I think it's important to lift that up.
Yeah, I agree. My friend Christia Donaldson, she was the founder of Thank God Is Natural Hair Products, and may she rest in peace. She had got breast cancer twice, but she wrote in her book how her mom died her senior year of high school, I think, or right after, and she was going to Harvard for the fall, and she really never had any quite grief counseling or anything. And so she felt like that was the disease that caused her to have breast cancer because she never really dealt with that. And I was like, that is powerful to think that. But this is why mental health is so important. And we just had a conversation about obesity earlier, and we talked about how mental health is in part of that too. You have to, it's a whole mind, body, spirit thing. We all work together. And if one is off, then it's not an even keel. You got to have them all together. And so I think people they don't want to realize how important, what's going on in their brain is, but it's really important. Your mental health is very important to how the rest of your body functions. And I think that that's not stressed enough somewhere down the line.
I was going to say directly, like stress causes our cortisol to spike, which then can affect insulin resistance and other like metabolic pathways in our body. There's a mind-gut connection directly. So absolutely, I don't know. I think that there's not enough conversations about how much our mental health impacts literally our bodies, like the specifics, and understanding that biology piece of it. I think hopefully helps put into context how important it is.
And then when you throw on top of it genetics, there are genetic factors that can affect everything, including mental illness. We had an aunt that jumped into the Detroit River and killed herself. And when I tell you, great aunt, when I got that clinical depression diagnosis, I said, oh, dear God, I need to be careful and pay attention because I do not want to end up like that. So, and I mean, I had heard stories about how she was when she was living. So I was like, no, I don't want to go down that road. And we had, I had another relative that lived in an adult group home because some man broke her heart and she just never got it together. I was like, oh my God. I was like, this is not going well. So you have to know your history so then you can look out for things. If you don't know your family history, you don't know what you're looking for.
Well, that also goes to the point of normalizing talking about this, because people will know the history around, cardiovascular disease, around diabetes, sickle cell, etc., but they will not know. It's always, well, I think. I wasn't sure.
Mm-hmm.
They said something was going on. Like, we have to give folks language, so that when their kids come in or when they come in, it's like, okay, because we actually then, it helps to expedite the formulation of what might be going on, then allows us to develop treatment strategies to help kind of provide relief quicker. It's so that we need to make sure that we're normalizing to get that history to provide.
And you know what? Patients come into doctors thinking that you know everything and you will figure it out. And so they don't give you the whole story. Either they don't know it or they want you to figure it out because you're supposed to know everything. No, that's not how it works. That is not how it works. This is a team effort. So if you bring all the information, then we can figure out what's going on and work from there. Because when you start at zero, like he said, it's going to take longer for us to figure out what's going on. But if you give us the information and say, oh, you know, when I was 10, I was molested, and then But if we don't know, then it's like, oh my God, where did this come from? Just all of a sudden you turned 18 and you have intimacy issues. You know what I mean? Like, you have to help the doctors out. And I think that's it's a lot of education that needs to go into patients to understand. You need to write things down so that you remember them, so that you tell the doctor, but you have to give them the full picture so that they know what they're working with.
But the thing I would add on top of that, because I feel like you brought up 2 points. One is people knowing the history to be able to provide it, which was part of what Dr. Reese was talking about. And then you piggyback kind of with the issue of people feeling comfortable with disclosure. And I don't feel like those are always the same issue. But one of the things I'd offer as a tip, it's one of the things my family does. My family's very open about health stuff. We all get together, everyone's drinking coffee and passing the blood pressure curve around. Is that just as we get together for food functions and things like that, that especially as people are getting older, just as, you know, we talk about family history as far as who's in the family, kind of that information leaving, is that, you know, I would suggest at some family get together, sitting around and everyone kind of given their different pieces of the history so you can put together a total family health history, and it can include physical health and mental health while everyone's together, because for a lot of families, everyone doesn't have all the pieces, because that's the things that happens with all the secrecy in a lot of these families is one person knows this, one person knows this, another person knows this, so that if you sit down sometime when everyone's just around and you collect it, well, then everybody can have the information. But sometimes it's also an issue of being able to access the information, which is why it's so important to start having open discussions, and it not just being there was this uncle or this dude that was in this back room like soul food that no one knew what was going on with him, or there was that one person that everyone says just wasn't right, or they'll say so-and-so that was on the heroin. Is that starting to really have open conversations. And when you have these conversations, the biggest thing to me is the intention is very important, that the intention is learning and helping.
Right.
And the other is the perspective we're coming at is kindness and lack of judgment. So that you can have these open conversations, to have the information, to be able to give the best history to whoever is taking care of you.
Definitely. And there's not, you know, and if you do have to take medication, it's not a big deal. You would take medicine if your stomach hurt. You take medicine if you had a headache. You take medicine if you had a toothache. You have to take medicine because something's not wired right in your head. Simple as that. And people just need to really be okay with it.
I was going to say, like, touching on that, I think there still exists a lot of shame, and that leads to the stigma, is like people feel ashamed that they're struggling with, you know, depressive symptoms, anxiety. They see it as a weakness. Oh, pray it away. You didn't pray enough. You didn't go to church enough. You know, this is like maybe a payback or some kind of a, not karma, something like that. And so I think once people understand like how common this actually is, and that this is something that many people struggle with, and it's not something to feel ashamed of. It's not something that you should parade around necessarily and, you know, wave the mental health flag and say, yep, I'm going through this. Like, not saying that you would expect people would be outwardly expressive about it, but that they at least are able to talk to a professional about it and seek the support from their family members, or, you know, their community supports, and their, at least their primary care,
Right.
to start with.
And so, you know, the next thing that people are going to say, and actually I did my show that's in the waiting rooms, it's called Keeping It 100. It's 100 seconds long, and all we did was mental health. So we did 3 episodes or 4 episodes about mental health. And the biggest barrier, of course, was money. And that's why people did not seek help. So do you 3 have any resources that you can provide that we can, you know, they can look up online or something to figure out how they can get whatever they need with or without insurance.
Yes.
Yes.
If you said what's the quickest, dirtiest, easiest way, is all in general, all communities have community mental health centers. In Georgia, they call them community service boards, but it's the same thing. If you search for community mental health center, you'll get it. Community mental health centers are designed just like a community health center, as far as they're designed specifically to help people that are uninsured, underinsured, or have some financial challenges as far as being able to access higher cost care. There are organizations such as the Boris Henson Foundation. There's also one called Black Men Heal, and both of those have some free mental health programming. But to me, community mental health centers, you can also, when you ask people, you can ask if they take sliding scales or have any other programs. And the other thing is there are two types of people that have the financial issue. One is the people that really don't have money. The other is the people that just don't want to spend the money. No, I mean, because these same people, and I've seen them, some of them have been my patient, and they'll say, oh, I don't want to pay for that. I don't have money for that. Does my insurance cover it? But they have $1,000 weave, new Jordans, and other things that show that it's not that you don't have the money. That's not where you value spending the money. So, the people that really just don't have money, or money's tight, because there's some people that make money, but it's tight at the moment. Those are some resources that are lower cost. And then you can go on websites like Therapy for Black Girls and things like that. And you can see if some people are taking sliding scales and things like that. But the other is we have to change the narrative to a point where this is something we value. Because just as you would value some nice shoes, some good dinner at a nice steak restaurant, or being at the newest place on IG with bougie brunch, I live in Atlanta, is that, the same people that will say they don't want to spend a $35 or $50 copay or pay $100 or $150 for a session are the same ones that if they looked at how they spent their money, there's $300 or $500 that just went to something random. Some of it is just, do you value getting to a point where we value our mental health to the level that we value other comforts. I'm off my soapbox.
But you're right. You're absolutely right. You have another resource?
I just would want to reiterate. I think in Georgia, the community service boards actually do a pretty good job. I also think a number of universities have external facing clinics that work with people. So Georgia State, and I'm thinking about Atlanta, Georgia State has a clinic. Emory has a clinic, and they do really good work. Cholla has a clinic that both trains providers and then has a very large behavioral health staff. They provide good services. And so I tell folks that these are, when you go to places where they're training people, they're typically, the people who are training them are really good at what they do. So those become good places to go. I think that we have to figure out how to impress, many of us who graduated from doing insurance work to doing fee for service, etc. We did that for a reason, because what the insurance industry remunerates for the services that we provide is ridiculous. And so there's an advocacy part for us to engage in, just in terms of hey, we say we have a mental health crisis, but you don't want to pay people a reasonable rate for doing what they do. Certainly more senior people are still probably not going to be with insurance panels, but I think that there are a lot of junior people now who are not taking insurance because of those kinds of things. And so I think we have to figure out how we level the playing field, because folks won't always be able to do that.
And I was just going to speak to Cincinnati. Here, we also have community mental health. We have several of them, and I know that exists as well as in Detroit. So I think the main issue, or the main factor, would be kind of understanding or asking around the resources in your community. A completely different soapbox, but I do think that mental health is something that should be a universal kind of covered health, and that people shouldn't have to pay out of pocket. However, I know that that is not, unfortunately, that is not the world in which we exist in, or the country in which we exist in. But I wish that that we had more of a universal healthcare system, or some kind of a healthcare system that valued, that prioritizing mental health access to all citizens in the country. But obviously, that's not the world we exist in. So.
Did we lose Dr. Renee?
I think we did. Oh,
No,
there's.
I just
She's,
Oh, can I add
she's
one more
back.
thing?
like
And just as we talked about community mental health centers, another term you all may hear around sometimes is kind of integrative health, or they'll have these community health centers that have behavioral health embedded in the actual clinic. Is so one of the other ways, if you have some, not even just barriers, but it's helpful to ask your primary care, because sometimes there'll actually be someone in the office, especially a lot of community health centers are starting to have more mental health professionals that are actually embedded in the office.
okay. So if you and also, and if you're in corporate, what is the name of those things they have? It's like the little number you can call.
The EAP.
EAP,
What's it stand for?
Employee Assistance Program.
Thank you. So those are also available, especially most corporations have those available for the adults. For kids, most schools still have a school counselor. Go talk to the counselor, and then they can, of course, escalate things to whomever it needs to go to. But you got to go talk to somebody, and hopefully you'll feel comfortable talking to the counselor. It's all about safe spaces, like they've said. So.
Yeah, I think a number of schools are also trying to intentionally create a behavioral health footprint in the schools.
Mhm.
So in Atlanta, we see a number of community-based organizations who are doing outpatient behavioral health within schools. So I hope that that's a trend that continues, because I think the safe space piece that you reference is critical.
Very. And also, as friends, if you notice that your friend, and this is adults and children alike, you notice your friend is just something's off, and maybe you talked to another friend and they were like, yeah, I noticed that too, or something, then maybe you guys should talk to them and suggest that they go see someone. Just be, and if you do it in a nice, loving way, and this is really your person, then it will be no judgment. They won't hate you for it or anything, but just say, I think that, you might, you've been sad for a really long time, or whatever you notice about them. You've seen, the last 10 times we went out, you've said no, something. Just, if you notice something, you should just say something. Like Dr. Erica said earlier. You notice something, say something. And like I said, that applies to children as well as adults, because you know your friends and how they act. And you know if things are different. So, and you might notice before the parents notice if it's a child, and you may notice before the spouse notices if it's an adult. So, please make sure that you say something. If you see something, say something. We're getting towards the end. I want to make sure that everyone knows how to find you guys, because you are great resources. Dr. Reese, I have more than once in the last 6 months put your information in a chat, because somebody was asking for Black boys mental help in Atlanta. And I was like, I know exactly who. So please make sure that everyone knows how to find you guys. So we will start with Dr. Berry.
I think the best way to find me would probably be on LinkedIn, and that would be just my name. So Ashley Marie Berry.
Perfect. Dr. Goodwin?
You can find me on the socials at Dr. Erica, DoctorErica. My parents used all the letters. I'm probably on IG and LinkedIn a little bit more. You can find my podcast. It's called Better with Dr. Erica on all major podcast platforms, or you can go to betterthepodcast.com. And if you're interested in me actually being your doctor, you can go to goodwinmed.com. That's goodwinmed.com, spelled like the compound word. And you'll get more information. And yes, I'm waiting to hear if Dr. Reese is taking new patients.
And actually, I was on Better with Dr. Erica. Okay, go ahead.
And I am taking new patients too.
So, Dr. Reese?
A couple different ways to connect with me. I too am on LinkedIn, do a decent job of monitoring that. I also can be reached through my outpatient practice, which is acomacounseling.com. I'm in a bit of a wait list situation now, but one of the things that I tell people is that I have 5 providers that I supervise. And so sometimes the more senior person that you may want that may be less available, I'm directly involved in the care of the patients that, the fellows see, that the other people in the practice see. So that's another way. And then I have a fairly significant academic identity, so I can also be reached at Morehouse School of Medicine at lreese@msm.edu. And then my practice email is lreese@acomacounseling.com. And for you, Dr. Goodwin, I'd be willing to have a conversation about a patient.
Appreciate you.
But you guys, I hope that you have picked up something from today from the State of Black Health for 2024. And hopefully, if you're watching the replay, you are enjoying this just as well and taking great notes and seeing about your family, because I definitely want to make certain that you get your family the help they need. We need the name. We need to spell the name of your practice, Dr. Reese.
You just did.
Oh, okay. I missed it. Hold on. Oh, AKOMA. Yes, I knew that. Hold on, you guys. I'm going to post it up here. Okay. That's it. So what was the email address again with the coma?
lreese@acomacounseling.com.
Yeah. So there you have it, because we do know that these Black boys really need it. So, and young men. So we so appreciative. Of course, he's only in Atlanta. But I'm sure the ones he's training, maybe they'll go to other parts of the country. Who knows? But Dr. Erica does do telehealth, so please make sure that you do check her out. And thank you so much, Dr. Berry. And we will have to have all of you back again sometime in the very near future. May is Mental Health Awareness Month, in case anyone didn't know. But thank you again, and everyone have a good night.
Thank you.
Thank you. It was a pleasure.